I'll be brave if you're brave. I'll be brave, but only if you're brave. Yeah, we can both be heroes, like soldiers in their nice clothes, like soldiers in their nice clothes, together. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this, like sailors in a tempest, like sailors in a tempest, together. And it could be just you and me. We'll be family. Just wait and see. So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening, everyone. Welcome to the living room. I know most of you, but I do see a couple of new faces. So I'm Danielle Hicks. My role here at the foundation is to oversee patient services and programs. So anything that has a patient touch or voice is my area of responsibility. We're so glad to have you guys here tonight. I don't know if any of you got a chance to sign in last night. Michelle and I were in Arizona, in a couple of different areas of Arizona, Sun City, and then Gateway Banner, but I don't remember the name of the city. Anyway, Gilbert, about an hour and a half away from one another, bringing this living room to the folks out there. So it was a really great night. We got back this afternoon, and we couldn't be more thrilled than to have Dr. Carbone here to talk with us tonight. And I don't know if you guys saw on the screen earlier or in some of the communications about what we're going to talk about, but we're going to talk about, it sounds really amazing, converting responses to treatment in order to find cures in ways we couldn't before. And this is across the stage spectrum where we're going to kind of take this conversation. So regardless if you're a stage 1 patient or a metastatic patient, what might that look like?
Online.
Okay, good.
Okay,
so
great,
just
great.
the happy anniversary thing, I'm sure some of you may have seen it in some of our external communications, but on St. Patrick's Day, this lovely here celebrated her 15th year cancer-free. Yeah. So she got a lot of well wishes. On St. Patty's Day.
I did.
Yeah.
But sometimes I was telling somebody tonight, sometimes I have survivor guilt, you know, to hear all these stories for 14 of those 15 years just makes me believe that maybe I got through that knothole to do what we're doing here. I hope that's the reason. Yeah.
Yeah.
Thank you.
So thank you, everyone. So now we're going to talk about
Now for something completely different.
completely different, but I know it's something that we've talked about in sort of varying levels and during various talks here at the foundation. That it's a conversation that is going to mean something to each and every one of you in the room, everybody watching, and those that will come back and watch later. And it's talking about how new improvements in treatments are moving us towards a cure. And as Dr. Carbone said earlier, the C word not being cancer, but the C word being cure. And what does that look like? And we're going to talk about it in 3 different sort of buckets, if you will. In the early diagnosis space, in the locally advanced space, and then in the metastatic space. So with that, I'm going to turn it over to Dr. Carbone. But before he starts talking about what this looks like in each of these buckets, tell us who you are and why you're here and why lung cancer matters to you.
Well, I'm the director of the thoracic oncology program at Ohio State University. And I have had a lifelong specific interest in lung cancer and lung cancer research, and have seen tremendous advances in the way we manage this disease in the last 30 years. And I'm very happy to be involved with organizations like the Dario Foundation that's doing great work in empowering patients and informing them on the latest treatments. So I like to divide lung cancer into really 3 buckets. There's the surgically resectable bucket, if you find your tumor when it can be taken out surgically. And then there's another bucket called locally advanced, where it's in one place in your body, but it's not possible to take it out. And then the third one is when it's metastatic and when it's spread to different parts of your body. And we have made amazing progress in all 3 buckets. We're going to start with the surgical thing. Still today, the best way to cure lung cancer is to cut it out, if you can do that. I mean, the surgical cure for lung cancer is about 50%, which honestly is better than any other modality at the current time. And you can't cut it out if it's spread or if it's advanced. And so we heard several stories about accidentally discovered lung cancer, and then they took it out and you're fine 10 years later. And if you hadn't fallen in the parking lot or had
got a car accident
and got that scan. Well, now there's 2 big randomized studies that show an improvement in lung cancer death rate by doing CT screening in high-risk individuals. And the older study, about 10 or 12 years old now, showed a 20% reduction in the deaths from lung cancer just by doing the scans. The newer study just was presented at a meeting recently, showed a 26% reduction in death in men and a 50% reduction in death in women from lung cancer. There's nothing you can do that's simpler than a 15-second helical CT scan. Yet, how many people in the United States do you think, and this is in the US, I'm not talking about in the Congo, right? In the US, what fraction of people eligible for CT screening get screening?
Anybody take a guess?
Take a guess.
5%.
Yeah, it varies, but it's something around 2%. 2%. What fraction of women get mammograms? 80%. What's going on there? You have in fact, the number estimates for improving outcomes in lung cancer are better for CT screening than mammograms are for breast cancer screening or colonoscopies, et cetera. So I think it's really tragic in this country that it's not more widely adopted. So the second thing I wanted to talk about for the early stage disease is the advances in surgery. Surgery, even in the United States, is not the same at different places. There are now board-certified thoracic surgeons who are specifically trained to operate on the lung, but most thoracic surgery being done in the country is being done by general surgeons. They do, heart bypass one day and then lung surgery the next. And it's been shown that the outcomes are better with trained thoracic surgeons, and they are able to do the excellent surgery without removing your entire lung, for example. They can do specific operations. And now they're doing the operations what's called minimally invasively. Years ago, people used to have foot-long scars and spend 2 weeks in the hospital. Now, literally, they do it robotically, and you come out in 2 days with a couple of Band-Aids on your side. It's just really remarkable. The recovery is much faster. The quality of surgery is better if it's done by someone who's trained. So if anybody you know is getting thoracic surgery done, Make sure that it's done by a board-certified thoracic surgeon at a major place. And we have advances in radiation therapy for early-stage lung cancer, where we can just do very tight field radiation and not do surgery at all in people who are too ill to have thoracic surgery, where in the old days they'd do palliative radiation and it would never kill the tumor. Now with new techniques, they can actually cure people with just the stereotactic radiation. Any other questions on early stage disease? Yeah.
You mentioned screening eligible people. What is screening eligible?
Well,
Like
right now
never
the
smoked?
definition of it is that insurance will pay for it, but it's basically the criteria for entry into the clinical trials that showed improved survival, and that typically is 30-pack year smoking history. You have quit less than 15 years ago, between the age of 50 and 80. And in that population, actually, the prevalence of lung cancer, if you just take 100 people with those characteristics, 1 or 2% of them will have lung cancer and not know about it. It's very high prevalence. So a huge issue is trying to figure out how to diagnose lung cancers that happen in other people, even never smokers. And that's an area of active research that is a very important area, but we could make a huge dent in lung cancer outcomes.
I think currently right now, and I'm repeating myself if you guys watched The Living Room last night, but in the US alone, there was somewhere between, it depends on what data you're looking at, 9 and 10 million people that qualify for this screening.
And it also
are
does,
not using it, yeah.
it also does include a familial presence of lung cancer, right?
It should, but often it doesn't.
Right.
So that's a long discussion,
yeah,
but we
exactly.
really need to better define those populations. Maybe the last thing I'll talk about is we're doing some clinical trials now combining immunotherapy and targeted therapies with surgery. Right now, the surgery followed by chemo or radiation is the standard of care, but I'm running a national study right now with immunotherapy. You're giving 2 cycles of immunotherapy before surgery. And in 10% of the cases, they're taking out the tumor, and there's no tumor there. After just 2 doses of immunotherapy, they've completely eradicated all sign of the cancer in these patients. So I think that in the future, we'll see a routine application of immunotherapy, at least, to early stage lung cancer.
And by eradication of the tumor, do you mean like total cell death?
Totally gone, no evidence
Yeah.
of cancer in the surgical sample. And that's, I think, remarkable. Even today, even in an early stage lung cancer, if you take it out and the surgeon says he got it all, you've got about a 50-50 chance that it'll come back and you'll die from it anyway.
Yeah.
So what are the pros and cons of doing that treatment before surgery versus after surgery?
It's not really known which is better, but we decided to do it before so that we could do biopsies and study the samples before and after and try to figure out why some people respond and why other people don't respond. But it's possible that before is better than after. We just don't know that.
Gotcha.
But I think that is in the future of treatment for early stage. So let's move on to locally advanced disease. This is where it can't be removed surgically, and that's called stage 3 typically.
It's driving me crazy.
And we heard someone over here talking about starting EGFR therapy and then being said, well, maybe you should do the chemoradiation. So the standard of care for stage 3 is chemoradiation, and that is a curative intent therapy. EGFR kinase inhibitor treatment generally is not curative. It suppresses the disease for a period of time. So your doctor was very insightful that if you could get the chemo and radiation, you should definitely get the chemo and radiation. But the fact was, up until a few months ago, they were using the same chemo and radiation when I was a fellow as they were today, and they were having 20% cure rates. But there was a very recent trial, we heard it mentioned somewhere, Pacific trial, that maybe I forget who mentioned it, right? Which is the first study in decades that actually showed improved survival in that population with the addition of durvalumab and immunotherapy. And that immunotherapy doubled the percent of people that were alive and progression-free at the end of the study. Really a very significant advance in the treatment of these patients. And I'm hoping that that'll translate into people who are cured with stage 3.
And the people that are afraid to have chemo, because I've watched all the same movies you've watched on TV, that make chemo look like, a terrible
durvalumab is an immunotherapy,
right.
But you are definitely, we heard several examples of people who take chemo and they look great.
Yeah.
And so if your doctor has considered all the options and he says your best option is chemo, even though you've had a great run for several years with a pill, it's definitely worth trying the chemo.
And I think it's important to have that conversation, what your concerns are with your physicians, because we've talked about this before. Everybody's worried about the side effects, but the drugs that they have to counteract those side effects
are better,
today.
and the drugs are better today.
Yeah.
And I can speak from experience too.
Yeah.
I'm a guilty cancer survivor as well, 19 years now.
Mm-hmm.
And I've had chemo, I've had part of my lung taken out, I've had radiation therapy, I've had all the same kinds of things that a lot of you have been through. And I understand chemo, we say it can be tolerable,
Right.
but it is strong medicine, and everybody responds differently.
Absolutely.
So anyway, that's a side note.
Yeah.
So let's talk about metastatic disease, which is actually the way most people today are diagnosed, unfortunately. And many of the people in this room, though I was actually surprised, there were quite a few stage 3s and 1s and 2s that I heard. Mm-hmm. When I used to meet a new patient with a diagnosis of metastatic lung cancer, on my very first visit, they often had the deer in the headlights look, and they just you weren't really processing everything. The day before, they were most concerned about what to make for dinner, and then today they're being told they have stage 4, and they look it up on the internet, and there's 4 to 6 month median survival. And I start talking to them about all the new treatments and the new genetic targets and the immunotherapies. Actually, back then, years ago, on that very first visit, I try to be very honest with my patients, and I used to tell them, metastatic lung cancer is treatable, but incurable. And I said, we can prolong your life, but it will come back. Now, with the new advances in treatment, I don't say that anymore. And let me just give you an example. So, with the new treatments of immunotherapy, there was a study called Keynote-10, which was one of the first trials of pembrolizumab. You dropped something back there?
It's important.
It's one of the first trials of pembrolizumab. And the way the trial was written, they almost didn't expect anybody to live 2 years, and so they just said, we'll stop after 2 years. Turned out, a reasonable fraction of the patients, in fact, in that study, I think it was 79 patients, reached the end of their 2 years of treatment. And you have to understand that historically, the average survival for metastatic lung cancer from diagnosis to death in the United States, not in third world countries, was 4 to 6 months. These are people that have been diagnosed with metastatic disease, and actually this was a second-line study, so this was the second treatment that they got. These are people who were alive and progression-free 2 years after starting second, third-line treatment. And so they stopped the treatment in these people. And most of those patients could stay off the treatment and at the end of the analysis had never recurred. And a few of the patients did recur, and most of those re-responded to the drug if they gave it again. But I now have multiple people in my clinic who were told that they had 4 to 6 months to live by their local oncologist, that, we're just going to give you narcotics and make you comfortable. And they're alive 4, 5, 6 years after taking immunotherapy, and now off of immunotherapy doing fine. And so I think there is an indication that we can be curing lung cancer with immunotherapy. Not in everybody, but in a small fraction of patients. And I think it's something that researchers really have to try to figure out how to make that small percentage bigger. And people ask me, what are the unmet needs in lung cancer? And I say, until you cure everybody, there are unmet needs. Mm-hmm. But the fact is, right now, there's a little bit of light at the end of the tunnel that you can cure people with immunotherapy. Now,
does it matter which type of immunotherapy? Like, how do you as a physician determine which drug you're going to give the patient?
Well, that's part of the problem is none of these drugs have really been compared head to head. And we use durvalumab in the chemoradiation patients because that was the study that showed the survival benefit. We use pembrolizumab with chemotherapy because that was what was used in Keynote 189, which is a study that showed better outcomes. So really, we're just learning how to use these drugs, which ones are best in what setting. With small cell lung cancer, it's atezolizumab and chemotherapy that showed the benefit. And so we don't really know which is the best one.
But we do sort of kind of know that if we couple it with a companion drug, it can boost the rate, the survival rate, maybe.
The response rate is higher if you add chemotherapy to immunotherapy, but it's still controversial. I have many people who've been on immunotherapy alone and done dramatically shrank their tumors and now are off therapy. And the Keynote 10 study I was talking about was just immunotherapy alone.
Yeah.
So one of the things we're studying in our neoadjuvant study, which is the immunotherapy before surgery, is we're doing hundreds of biopsies and tests on those tumors to try to figure out why some respond and why others don't respond, figure out other new types of immune therapy that might work in one person and not another. So there's a lot of active research in that area. But I wanted to talk a little bit about what's called the driver mutant therapy, targeted therapy, and that's the EGFR and the ALK and the ROS and RET and TRAC and those kinds of things. Those therapies work great, but also today really aren't curing people. They could work for I've had people 7, 8 years on a targeted therapy, but generally people will recur. And so we can be happy with the progress in the targeted therapy space, but the fact is that we're generally not curing these people. And one of the things that we heard about earlier is I think we need to research how to convert those responses to cures with driver mutant tumors. Unfortunately, EGFR, ALK mutant tumors tend not to respond to immunotherapy. So that's probably not the answer to the EGFR, ALK mutant tumors. We have research in my own lab that looks at why we're not killing off all the cancer with these targeted therapies. So, like my patient I told you with that painting, the Blue Beautiful Skies painting, people have dramatic responses. The tumor can even go away completely on scans in just a few weeks. But there's always a little kernel of cells, some few cells left that aren't killed off by that drug that end up growing back out. And we have an active research on trying to figure out why those cells didn't get killed. And so what we talked about a little earlier was the paradigm of other diseases that we are effectively controlling by combinations of therapy. So in the early days of, say, leukemia or lymphoma therapy, they were giving single drugs to patients. They were getting great responses, but it always grew back. Then they figured out combinations of treatments to give right up front to a patient, and they cured people. And I firmly believe that with the targeted therapies, that if we figure out why that last little nidus or little kernel of tumor cells aren't killed by the Tagrisso or the alectinib, then we can put in another drug that kills off that last little bit of the cancer. And maybe we can treat these tumors with 6 months of therapy like we treat a lymphoma and cure these people.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. Yeah, we can both be heroes, like soldiers in their nice clothes, like soldiers in their nice clothes, together. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this, like sailors in a tempest, like sailors in a tempest, together. And it could be just you and me. We'll be family. Just wait and see. So I'll be brave if you're brave. I'll be brave, but only